Hello, good morning. I'm Dr. Ajay Padmanabhan, Consultant Critical Care in Apollo Main Hospitals. I'm here to talk about critical care management of Covid-19 infected patients. So I will be demonstrating on the initial management, on the management of patients with hypoxia, management of patients with severe hypoxia who need intubation and ventilation, on how to don and doff personal protective equipment. Assisting me with this video is Mr. Ebi, our respiratory therapist. So let's begin. So COVID-19 patients with pneumonia who require admissions are often clinically stable, but some patients may have critical illness and predominantly hypoxic respiratory failure. The principles of managing these patients is most of the patients, as long as the saturation is above 90%, they will not need oxygen support. If the saturation is below 90%, they will need oxygen support through a nasal cannula or a face mask. But if they do not improve with conventional oxygen therapy, we may have to think of higher oxygen therapies. The options that are available to us are high flow nasal cannula, oxygen therapy, and non-invasive ventilation. So the ideal oxygen targets will be 92 to 96%. If they are not able to maintain the oxygen targets with conventional oxygen therapy, we have to use higher oxygen, and here we have the high flow nasal cannula. We suggest that in case of failure of oxygenation with conventional oxygen therapy, to use high flow nasal cannula oxygenation, preferably over non-invasive ventilation. But if the patients are not comfortable on this device, or if they require more oxygen, a short trial of non-invasive ventilation can be tried. But it has been proposed that the aerosolization of the virus may be higher when using non-invasive ventilation. So preferably we would like to use high flow nasal cannula over non-invasive ventilation, but in some situation to use a short trial of non-invasive ventilation. But if the oxygenation does not improve with conventional oxygen therapy or with high oxygen therapy such as HFNC or NIV, then we will have to proceed towards intubation. So if the patient does not improve with conventional oxygen therapy or high flow nasal cannula or NIV, the patient may need to intubation and mechanical ventilation. Now, what we need to know about patients with COVID pneumonia who need to be intubated is that we need to don personal protective equipment. Donning personal protective equipment may take up to 10 to 15 minutes. So, and preparation of intubation may also take some time. So, it's preferable to plan intubation early and not do it in an emergency manner. It is advised strongly that personal protective equipments are fully donned and checked before we enter into the patient area. The patients are preferably admitted into a negative pressure isolation room. If a negative pressure isolation room is not available, a closed room with separate exhaust and HEPA filters, if possible, is advised. So we will be seeing how to prepare for intubation. First, we will divide it into three phases: a pre-intubation phase, an intubation phase, and a post-intubation phase. During the pre-intubation phase, planning and preparation is important. With regards to planning, we will need to have adequate personnel. So as for this particular situation, we'll have to divide our personnel into two teams: a team of personnel inside the room with the patient and a team of personnel outside the room, outside the isolation room, away from the patients, who will be available whenever necessary. So the team of doctors or respiratory therapists or nurses inside the room will have to don full personal protective equipment while inside. First, the team leader should be the person who must intubate the patient. Senior most doctor must be the person intubating the patient. Senior most doctor to brief the team regarding the preparatory phases and the plan of intubation. So first, I will discuss with my junior doctor on what will be the plan of intubation. So in the preparatory phase, we'll have to do an equipment check. First, it is important to assess the patient's airway and ascertain the difficulty of intubation. An anatomical assessment and a physiological assessment will be done initially. Now, I have coordinated and debriefed my respiratory therapist on the equipments that I need. We will have to have plans for intubation. A plan A, a plan B, and a plan C is absolutely necessary, and it has to be debriefed. Equipments that are required for plan A are devices for oxygenating, the face mask, a Bain circuit, or an ambu respirator. In COVID-19 patients, it is preferable to use a video laryngoscope as the primary plan A intubating options. But if you are not familiar with the video laryngoscope and not as started the learning curve yet, the conventional laryngoscope can also be used. The conventional laryngoscope with an adequate smaller size blade should be available. Endotracheal tubes of 2 different sizes at least, tube ties and inflating cuffs. This is for plan A. If oxygenation and ventilation fails with plan A, plan B equipment should also be ready. Plan B equipments are nasal airways of different sizes, oropharyngeal airways of different sizes, and LMA with syringe for inflation, alternate laryngoscopes such as a McCoy laryngoscope or a video laryngoscope, and a intubating bougie. If plan B fails, then it may be a situation where we cannot oxygenate or cannot ventilate. Then we'll have to go towards plan C, which will be cricothyrotomy. It is preferable in COVID-19 patients not to use a fiber optic bronchoscope for intubation in view of high aerosol generation. So next step in the preparatory phase is to load the drugs necessary for intubation. Then you should discuss this with the nurse who will be in the bedside, and the medicines should be loaded outside the isolation room and must be brought in after the medicines are fully loaded into the patient side. The intubation will preferably be a rapid sequence intubation, and the drugs are preferably rapid and shorter acting. Here what we advise for our intubation, first is to load drugs for induction, which will preferably be a ketamine or etomidate, because they cause less hemodynamic changes compared to the alternate options. Fentanyl for analgesia. Midazolam can be alternatively used for induction too. For muscle relaxation, we advise to use succinylcholine, or if there are contraindications to succinylcholine, to use rocuronium. We also advise that you load emergency drugs necessary in case of hemodynamic changes during intubation. Keep emergency resuscitation drugs, atropine and adrenaline, ready, as well as alternates such as ephedrine must also be loaded, ready. Noradrenaline infusions are also preferably loaded in syringes and kept ready and continued if there are persisting hemodynamic changes after intubation. For sedation, syringes should also be loaded as prepared for post-intubation. For mechanical ventilation must also be kept ready. So after setting up the airway equipment and the loading of the intubation medicines, the next step is to set up the ventilator. In order to set up the ventilator, first step is to set up the circuits. We have the inspiratory limb and then the expiratory limb. At the beginning of both these limbs, we suggest to use bacterial and viral filters to be attached at the beginning of the limbs. At the Y, we advise that we attach this setup with a ETCO2, with an ETCO2, HME with bacterial and viral filter, and a closed suction catheter. The next step in the setting up of a ventilator is to attach the inlet for oxygen and air. It's important to also check the suction equipment before proceeding with intubation. After setting up the circuits and the inlets, a basic ventilatory setup needs to be made. We prefer to start off with an assist control mode of ventilation, preferably with a volume control. Set up a tidal volume of approximately 6 to 8 ml per kg body weight. A respiratory rate and minute ventilation according to the patient's need needs to be set up. You can start off with a PEEP of around 5 and slowly titrate up. Start with an FiO2 of 100% and slowly titrate down. So after preparation, it is important to have a room layout and decide who are the team members who are going to be inside the room and outside the room. What we are advising is the senior most physician will be the intubating doctor. There will be the respiratory therapist and who will act as the airway assistant, and then a staff nurse who will be administering the drugs and looking at the monitor. There will be 2 other members who will be outside the closed door, one backup doctor and a runner nurse in case of emergencies. The next step is donning of personal protective equipment. It is important to identify specific areas in the hospital or ICU for donning, separate rooms for donning and doffing personal protective equipments. It's a good idea to have a checklist available, parts of the personal protective equipment, order of donning, and also it's advisable to have an assistant or a buddy to assist with the donning of personal protective equipment. So the parts of the PPE are: first, chlorhexidine or alcohol based hand rub, shoe covers, full body jumpsuit, sterile gloves, unsterile gloves, head cover, face shield, and the N95 respirator. Staff entering the patient area involved in aerosol generating activities such as intubation, bronchoscopy, sampling are required to wear the N95 respirators. N95 respirators differ from simple face masks. Step 2, shoe cover. Step 3, full body jumpsuit. Next step, N95 respirator. So you have the N95 respirator, you have 2 straps. One strap is to be applied on the nape of the neck and one below the ear. So just bend down. Next you'll have to make sure about the attachment. Pull it over your nose and then use 2 fingers to seal it onto your face and make sure the chin strap is attached fully. Now we have to check for fit test. In order to do a fit test, take deep breaths, inhale and exhale. If you can feel air leaking either from the face or nose areas or below the chin, if it is from the nose area, adjust the nose piece. If it's from the chin, adjust the strap. Next step, head cap and neck cover. Make sure the neck is covered. Next step, donning sterile gloves. Pull it over your sleeves. Once the sterile gloves are donned, don one more pair of unsterile nitride gloves. Next step, face shield. While performing intubation or any other aerosol generating activity, need to use face shield. After completion of donning the PPE, it's important to ask your buddy to check completeness of PPE. Is it complete?
Yes, sir. Fully complete. Complete.
Now that the preparatory phase of intubation is over, now we can proceed with intubation. This will be the layout. The senior most physician will be the intubating physician, donning full personal protective equipment, including face visor. The respiratory therapist will be ready with the airway equipment, also donning a full personal protective equipment, and a nurse who will be administering the drugs and observing the monitor which will include non-invasive blood pressure, ECG, SpO2 and end-tidal carbon dioxide. This will be the team inside the room. Outside the room, we will have one doctor and a runner nurse. The first step is pre-oxygenating the patient. If the patient is already on a non-invasive ventilation or a HFNC, it is acceptable to pre-oxygenate the patients first with the pre-existing device. Otherwise, we can use the face mask for pre-oxygenation. The setup is with the face mask and the Bain circuit with a HME bacterial and viral filter in between the circuit and the face mask. Explain to the patient that a face mask is going to be kept on his face. Pre-oxygenation must be continued for 5 minutes while keeping a reasonably tight seal on the patient's face. Pre-oxygenation is important because we would ideally like to avoid ventilating these patients with the Bains in order to avoid aerosolization. After pre-oxygenating the patient for 5 minutes, the rapid sequence medications as already described will be given by the staff nurse. Once the patient is induced, our intention is not to ventilate the patient. Ventilating the patients with the Bain circuit may result in aerosolization, but if the patient has severe hypoxia, we may have no other option but to ventilate them. In that case, we will use a ventilation with low tidal volumes. Also, it is preferable not to use any Sellick's maneuver or cricoid pressure, as the patient may vomit or cough, causing further aerosolization. Once the patient is completely under the effect of the sedation anesthesia, we will proceed with intubation. Here we will use the CMAC video laryngoscope. Suctioning whenever necessary. Yeah, remove the stellate. Inflate the cuff. It is advised to directly attach the patient to the ventilator with the preset circuit. Now confirm the intubation, the tube position by EtCO2 and auscultation. So post the intubation, if the patient we have to start continuous sedation, If the patient has hemodynamic instability, start vasopressors. If the patient requires invasive monitoring, it is preferable to put the lines an hour or so after intubation, because immediately after intubation there will be plenty of aerosols in the environment. We need a chest X-ray to confirm the position of the endotracheal tube, and then as per our initial discussion, the ventilators will be set accordingly and titrated as per the oxygenation needs. The next step is doffing of personal protective equipment. There must be a separate area for doffing all the personal protective equipment. You have to remember that the front surface, the gloves are contaminated and they need to be disposed of without cross contamination to other workers. So step 1 is to remove the gloves. Make sure you don't touch the front surface. Next step, remove face shield. This will be disinfected and reused. Next step, you will have to remove the bodysuit. When removing the bodysuit, make sure you don't touch the front surfaces and gradually wiggle out your arms without touching the front surface. Just roll the gown along the inner surface and dispose. Next, shoe cover. Finally, gloves. Next step, hand hygiene. And then remove the N95 mask. Make sure you don't touch the front surface of the mask. Bend your head down, pull the straps and remove the N95 mask. And then again hand hygiene. This completes the doffing of personal protective equipment.